The next speaker is Dr. Eugene Downer. Dr. Downer is professor of medicine at University of Toronto and is an electrophysiologist at Toronto General Hospital. And he'll be talking to us about VT ablation.
Okay, again, it's a pleasure to be here, and I thank everybody for the opportunity to come. Can we have the first slide? I thought we'd talk in this session about ventricular tachycardia. And the first slide, just to remind people that they're not a comprehensive list of underlying substrates, but the most common one we have to think of is ischemic cardiomyopathy with a remote infarct. Increasingly, we focus more and more on idiopathic cardiomyopathies, acute myocarditis. I mentioned the giant cell case this morning, but there are other ones that too present with not only electrical storm, but very frequent arrhythmias. ARVC is sort of increasingly sort of coming with some perhaps early reports of success from the epicardial space in cases that are otherwise refractory. And depending on which part of the world you will, Chagas disease is also something to be considered. First of all, just quickly to just discuss the antiarrhythmics. I guess Stuart Connolly and others from Canada did the OPTIC trial, just looking at optimal sort of antiarrhythmic therapy for VT, and I think here's an ordinate in terms of recurrent success. The bottom line is that the most successful antiarrhythmic combination was amiodarone plus beta blockers compared with sotalol or with beta blockers alone in terms of suppressing ventricular arrhythmias. But I think we're all sort of at the stage where, despite various antiarrhythmics, we're still left with a hardcore of VT cases that really do not respond. The other cases mentioned at the bottom, if we just go back, that there's still a high rate of discontinuation. So in this study at 1 year, 18% patients came off amiodarone, 23% of those on sotalol, and some of the beta blocker too could not tolerate them particularly well. So if we first of all focus on ischemic VT and catheter ablation in the role, we already discussed this morning on the one presentation, which is the electrical storm scenario. The other one is the sort of stable but fast walk-in type of monomorphic ventricular tachycardia due to a remote infarct. And increasingly, we're also seeing this kind of scenario where people have a defibrillator, had an old infarct, but now coming in with something that's barely a tachycardia. This is ventricular tachycardia at a rate about 102 per minute, but these are often very difficult to treat already. They're on beta blockers, amiodarone, everything, and extremely symptomatic. So there's very little, the rates are so slow that ATP doesn't work or the recurrence, so where to go with these. So I'm going to go back to the future. I think increasingly when you live long enough, you find that things tend to cycle back, and I think it's sort of interested now that, first of all, we learned a lot of lessons in the 80s from intraoperative mapping. This, I think, in places where they do have a focus on therapy, non-pharmacological therapy of ventricular tachycardia, there's increasing interest in some selected cases as going back into the OR where everything else fails. So this is just a display of our epicardial array, which gave us simultaneously 112 epicardial electrodes. We had balloons that could be put in with a patient on cardiopulmonary bypass in the right ventricle, in the left ventricle with silver bead electrodes. So we had a total of over 300 electrodes that we recorded simultaneously, intraoperatively. And the next case is the kind of display of these all simultaneously. This is actually in a case of Chagas cardiomyopathy with VT. Just to put this in context, there's a three-dimensional image where one tachycardia originated from the RV epicardium, went into the blue area, which is RV endocardium, and on a broad front across the septum and into the LV endocardium and out. In the same patient, there was a LV endocardial site that went in the opposite direction. So these are things that I think intraoperative mapping still potentially has a role. And in Toronto, we still actually use it, not very often, but for cases that present with tetralogy of Fallot, and this is one example of that, where we have the right ventricular balloon and the epicardial sock. There's just a passive breakthrough over the RV outflow tract here, but in fact you can see here, which is the right ventricular endocardial balloon, you have a reentrant circuit that typically loops around the VSD patch between the pulmonary valve and the top of the VSD margin and through the body round and round. So cryoablation in this area is usually curative in these particular cases. And this is some of the lessons that were learned in terms of mechanisms in the chronic established infarcts VT. So this is a lead surface lead 2 in a patient. We have the left ventricular balloon in. The earliest site of origin was at this particular site, and with sort of a bi-front activation through the left ventricular endocardium, but then return by a sub-endocardial kind of conduction through this portion back to the site of origin. And here you can see selected electrograms from the balloon showing both systolic and diastolic activation going through, maintaining this particular tachycardia. And in red here is the critical return path that required resection and cryoablation. It's kind of useful to have these as a kind of paradigm in your mind when you're dealing with the roving electrodes. We were delighted when Boston Scientific came out with a basket catheter, which was 64 electrodes, with 8 electrodes on 8 splines. This could be introduced very nicely, as you can see in this, through a retrograde approach with a sheath in the left ventricle positioned in the left ventricle and provided 64 simultaneous points in the left ventricle. I think there's still a need for this kind of a array, and we'll come to that in a bit later. So here's one application of this case. This is a patient who had a remote inferior infarct, presented with a recurrent VT, but when we took him to EPS, all we could bring out was sort of short runs of non-sustained VT, but the morphology was exactly the same as a sustained episode. So with a basket array, we were able to look at the sequence of activation here, and in fact it was very similar to what I showed with the balloon catheter, where you had systolic followed by diastolic activation coming through, and this loop was in that particular circuit just going round and round. The reason that this tachycardia terminated was, you can see in the next slide, so we had systolic activation here, coming back diastolic up here, just jumps around. The next slide shows that basically in the diastolic return path there was a block at the exit site, and this is the reason for the tachycardia being non-sustained. Here's the same sort of VT just basically shown on a flashing light display using that basket in that same patient, ventricular tachycardia. So you can see it sort of coming down diastolic up here and across. This is information that you can get straight away about where the circuit is, and I think we badly need it, even though we have CAR2 EnSite and various other things. Here's another application of the basket in a patient who had incessant ventricular tachycardia. We talked about electrical storms or frequent discharges, but some of the patients present very dramatically with just a VT won't stop. So this guy had a remote inferior infarct, had a VT continuously going along, nothing worked, recurrent burst pacing, would just immediately return back to his VT. We mapped him with the basket catheter, and turned out he had a beautiful figure of 8 on the endocardium. Here's 2 selected electrograms from that spline with early diastolic and so pre-systolic, mid-diastolic potentials here, burning at this particular site, resulted after 2 weeks of incessant tachycardia and successful termination. Let's switch for a moment now to the walk-in type of VT. So this is the slide I showed earlier, a VT at about 210 per minute. This is actually the profile. He was a CV surgeon that implanted most of our pacemakers and defibrillators. And then he walked into one of our colleagues' offices saying it didn't feel quite right. And in retrospect, probably was in ventricular tachycardia for about 12 hours before coming for that. So he had this walk-in VT. Our approach, as I mentioned earlier, is with cases like this to take them first of all to the cath lab and just try and see what it takes as a baseline in terms of inducibility. So here you can see we're pacing single extra induces his tachycardia. Sorry, the mouse is a bit squeaky. Single extra induces a morphology of tachycardia, so we know what it takes to induce the tachycardia. Here, for those of you that probably not familiar with the CAR2 system, it really is very attractive. This is an accelerated representation where you're collecting points by just moving around point by point in the chamber of interest, and very rapidly you get the anatomical reconstruction of that shell, as well as the electrical features that you can include. This is actually an atrium. The latest version is the CAR2 3, which we started using just less than a year ago, and this is really quite addictive. You just swirl around the catheter. It could be a lasso catheter or something. Again, this isn't left atrium, but very rapidly you can get an extremely accurate reconstruction of the shell that you're looking at, and that's shown on the next slide. So this is the kind of picture that you can get, reconstruction of the left atrium and the veins, which is approaching the kind of details that you get on a CT scan. So this is, I think, useful advances in terms of catheter mapping and electroanatomic mapping. Moving on to what is the substrate. We mentioned the chronic infarct. This is from Andy Witt's work, but lots of other people shown. So the normal situation, of course, is before an infarct, the myocardium acts as a volume conductor syncytium. When you do get infarction, you had surviving strands that get separated by scar tissue and lose their side-to-side connection. The end result is really to get the separation and isolation of individual tracts, so then you really get a maze kind of zigzag conduction. And that's what this leads to, is the ability to identify these late potentials even in sinus rhythm, and certainly with ventricular pacing, and a lot of the people that do have a substrate and a history of ventricular tachycardia. And this is from the group at Westmead in Australia, showing that these late potentials you can actually pick up on signal averaging techniques that sort of indicate this kind of substrate. This is from John Miller's work too, showing the old Pennsylvania peel, where again here's in sinus rhythm. You get these late potentials that we particularly find the target of interest. They do the resection, those potentials disappear. They put the resected area back on, you get attenuation of the systolic electrograms, but of course you disconnected the late systolic scars that were resected, so that